Discrimination within the healthcare profession is well documented. There have been efforts to cut down on discrimination through legislation, like the Civil Rights Act of 1964, but they are historically ineffective. To understand why, we need to understand the effects of implicit bias, as well as the indirect causes of healthcare discrimination. The problem with legislation such as the 1964 Civil Rights Act is that it only addresses explicit bias, the explicitly racist actions of individuals. The legislation does not address the issues with implicit bias. Implicit bias is a subconscious application of prejudice or stereotype in a person's actions. It is impervious to legal action because it is difficult to trace outside of broad trends, and people aren't always aware that they are acting out of bias. Sadly, there is a lack of research concerning the causes of implicit bias within the healthcare system. There could be any number of variables that could affect a person's decisions, so linking them entirely to implicit racial preferences is difficult. The wide-reaching impacts of those biases are also far from being completely understood. Statistically, minority patients are less likely to receive proper medical care, often being prescribed less potent painkillers or antibiotics than white patients with similar symptoms. Their symptoms are often taken less seriously by white doctors, and in some cases, patients are treated as hostile. One cause of these issues is the lack of diversity in medical staff, with white physicians accounting for approximately 56% of their own field. One particular study on the subject of implicit bias in the medical field was conducted by Dr. Quinn Capers, Associate Professor of Medicine at the Ohio State University College of Medicine. It addressed the white bias of medical staff and respected university staff. In the study, 140 members of the university's admissions committee took an implicit association test designed to measure implicit bias. The test had participants pair faces with either positive or negative words as they appeared on screen, measuring the latency between the faces popping up and a response to quantify the strength of each association. The results overwhelmingly supported the hypothesis that implicit bias favoring whites is significantly present in both white male and female groups. However, the bias was much weaker for white females. Dr. Capers also found that African American participants had insignificant or no implicit bias at all. The results of the study proved that greater representation of African Americans and white women on the admissions board would lead to less implicit bias, but their findings can easily be applied more broadly. The study focused particularly on African Americans, but its findings could likely be applied to any minority group. The study helps us understand a key problem of the medical industry. Implicit bias limits the diversity of medical workers. Establishing hiring quotas for BIPOC, or otherwise incentivizing their hire, can go a long way to addressing the issues of bias. BIPOC are significantly less likely to harbor the same implicit biases commonly found in white staff. Implicit association tests should also be utilized more commonly to better educate medical staff about their own implicit biases and promote personal change. A major contributor towards the disparity between white and BIPOC healthcare is the prolonged aftermath of redlining. Redlining refers to the practice of denying services such as a loan or insurance policy based on income or race, and was made illegal in 1968. Currently, privatized healthcare limits the presence of facilities in previously redlined communities due to economic concerns. One solution to this problem would be to push for high-quality healthcare as a right for U.S. citizens. President Biden has already taken some actions towards making healthcare more accessible, such as a public insurance option that offers lower premiums than private agencies. However, along with many Americans, he remains opposed to Medicare for all. The best option to push for meaningful legislation would be to remain critical of moderate efforts and attempt to push future candidates in the direction of public healthcare. We can't expect to end racism or even understand the full extent of its impact on our culture, but by coming together and deliberately working to heal the systems that promote and thrive in racism, access to quality healthcare without bias can become